Hello, this is a case of robotic tubal recanalization surgery. This patient has Pomeroy Technique of Tubal Ligation Tubectomy done 6 years ago, and now we are doing the recanalization. So this is the proximal end of the tube. And the sharp cut is cut so that the serosa and the mucosa both should cut. And this is the cold seizures we are using without any energy, and here we can see that lumen has opened because the blade of the seizures is directly entering into the lumen. So it is a patent lumen, and after that we have cut it, little bleeding, you can do irrigation and suction. It is not good to use the energy. And now this is the distal end. Fimbria of this patient is very nice, it is fine. And this is the distal end of the tube, fimbrial end of the tube, and this is cut. And fimbria is laterally in the fluid, it is healthy. And after that, this is first stitch is taken on the mesosalpinx. The purpose is that we are using 4-0 suture with the 22 ml round body needle. Mesosalpinx has to be approximated first so that the tension over the suture line of the tube will not be there. And the simple surgeon's knot is tightened. So this is approximation 2-1-1, first time double wrap, followed by 2 opposite alternating wrap. After that, this is 6 o'clock position. Out to in, and then in to out at 6 o'clock position. Six o'clock means towards the mesosalpinx. So clock has to be positioned in a way that the first is towards the mesosalpinx. And all interrupted surgeons knot. So generally we take only 1 suture on the mesosalpinx and 3 over the tube. At 6 o'clock, at 10 o'clock, and at 2 o'clock. And 6 o'clock means towards the mesosalpinx, so 6 o'clock is done. And now, second knot we will take at, this is at 2 o'clock position. And first 10 and then 2, this is 10 o'clock position. In relation to the first knot. So if first is at 6, then this is 10. As we know in the robotics, the tactile feedback is not there, so during tightening the knot, we have to be careful that overpressure should be avoided, otherwise suture can break or tissue can cut through. So this is 10 o'clock. And then the last suture posteriorly at 2 o'clock. So this is the great advantage of robotic, that your bite can go from below up. So out to in and into out. In laparoscopy, this bite will be very difficult to get posteriorly, but in robotic it is extremely easy. And this is 2 o'clock position. Because of the needle prick, sometime the minimum bleeding will be there, but for that coagulation should be avoided. Once you will take a bite, automatically bleeding will stop. So this is the fourth knot. First was on the major salpinx, then over 6, 10, and this is final 2. Double layered suturing is not good. That has a problem that it can create more stricture due to the foreign body overload. And generally we don't put any stent also. That also has not been reported in many of the literatures, that it can create more infection, especially if you are pointing toward from the cervical side, and it doesn't have any advantage in the prognosis. So good approximation and ages should be approximated, that is better. Now this is the left side. This is proximal end which is cut. Here is the distal cut end. In Pomeroy technique generally, they destroy the more amount of the tube. The reversal is more successful in cases of fallopian, filsi clip or Hulka clip. But luckily the fimbria, as we can see laterally, fimbria is good. In this patient, the amount here, the lumen, the instrument is going into the lumen. Now the tissue is dropped down. Now the first bite we will take on the major salpinx, so that the edges will come nearer and taking the approximation will be easy. This is major salpinx of other side. It will be approximated. Tube has rotated to other side, but it will correct once we will take the major salpinx. Then it will come at correct position. So major salpinx is now approximated, and then this is 6 o'clock position. That is towards the major salpinx. Out to in. this is into out. Then now this is 10. But here we have planned to do posterior first. Precision of the robot is much better for suturing compared to laparoscopy. Because of articulation of the instrument, it becomes very easy to suture. We are performing robotic surgery since year 2010 itself. So far we have performed more than 1,000 cases, and in our experience the effect of tubal recanalization is very good. The success rate is much better compared to laparoscopy. Now another suture. Here we have not used any vasopressin for transient ischemia, and we have not used any energy source. No cautery was used, no harmonic, no bipolar at all. So immediate faster suturing will prevent the bleeding. And if it bleeds, you can irrigate little bit, because if you will not damage a lot of mesosalpinx, then much bleeding from the edges will not happen. And here one extra we have taken, although it was not required. Just one extra on the seromuscular at 12 o'clock position. That was 4 suture. And it is over. We will do the tubal patency test later after 3 months. Right now doing will unnecessarily bring the infection from vagina. So we don't do it at this time. It is cut, and then suture will be taken out. And all the tissue can be taken out. Here biopsy forceps. And biopsy forceps will catch all the tissue and it will be brought. So thank you very much for watching this video. This was just a simple case of tubal recanalization surgery by WLH robot. Have a nice day.